Hey everyone, today we will be discussing the role of the acute care nurse practitioner. This presentation was created by Allison Biggerstaff, myself, Caitlin Sarda, Alyssa Gramstad, Amber Groneweg, and Elizabeth Haig. The American Association of Nurse Practitioners defines nurse practitioners as licensed, independent practitioners who practice in ambulatory, acute, and long-term care as primary and/or specialty care providers. An acute care nurse practitioner is an advanced practice nurse that works in the acute care setting. According to the World Health Organization, the acute care setting is typically where treatments are time-sensitive, individual-oriented, sudden, often unexpected, urgent or emergent, and without rapid intervention could lead to death or disability. An acute care setting is where most diagnostic and curative actions take place. The most common example of this would be the hospital. So now that we know what an acute care nurse practitioner is, we will discuss how to become one. First, anyone interested in becoming an acute care nurse practitioner would have to graduate high school. After high school, one would obtain a registered nurse degree and pass the state licensure exam. There are many different avenues into obtaining a post-RN degree, such as the RN to BSN track, the RN to MSN track, but nonetheless, to become an acute care nurse practitioner, it is required to obtain a master's degree or higher at an accredited college in the acute care nurse practitioner track. There are generalized tracks as well as pediatric, neonatology, and adult gerontology tracks. Most master's programs will require 1 to 2 years of clinical experience in an acute care setting before becoming accepted into the program. After graduating with a graduate level degree as an acute care nurse practitioner, individuals are required to pass a state licensure exam. There are also certifications that can be obtained depending on the specialty that one chooses to go into. This slide shows some subspecializations of a nurse practitioner. So depending on each state requirement and what subspecialty is chosen, it's usually required to have a postmaster's certification. This is obtained through either more schooling, more clinical hours, or both. So this slide shows more so the physical areas that an acute care nurse practitioner would work in. An acute care encompasses a range of clinical healthcare functions, including emergency care, trauma care, pre-hospital emergency care, acute care surgery, critical care, urgent care, and short-term inpatient stabilization. A few of the areas that an ACNP could typically work are trauma care and acute surgical needs. These would be things such as life-threatening injuries like myocardial infarction, trauma, appendicitis, or an accident victim. Urgent or ambulatory care is care outside of the hospital or emergency room and is usually after clinic hours. This is on a walk-in basis and is for less severe situations, such as an injured ankle or fever of a child. Another area would be pre-hospital care, emergency room, or short-term stabilization for things such as intravenous fluids and stabilization before a critically injured patient would go to the operating room or get transferred for more specialized care. Another short-term stabilization area that an ACNP may work in would be the intensive care unit. These units are for patients who need specialized care and constant monitoring, such as those who require intubation or are in a coma. As previously stated, acute care nurse practitioners typically treat patients that are acutely ill with sudden, unexpected, urgent or emergent conditions that without rapid intervention could lead to death or disability. Some examples of areas an acute care nurse practitioner would work are included on this slide. So this is a map from 2017, and it depicts the state-by-state scope of practice for NPs. States that are in blue, their NPs have full practice rights, meaning that they can evaluate patients, diagnose, order and interpret diagnostic tests, initiate and manage treatments including medications. The states in yellow represent reduced practice, meaning that the NP can evaluate, diagnose, order, and interpret diagnostic tests, but they need a physician oversight to prescribe medications. And then finally, the states in the red represent restricted states, meaning that an NP would need physician oversight to prescribe, diagnose, and treat patients. As noted on the map on the previous slide, the scope of practice is on a state-by-state basis and is determined by the State Board of Nursing of each individual state. As of 2017, 22 states have granted their NPs full practice rights. Although all NPs can diagnose, prescribe, and treat patients, some need physician oversight for part or all of their practice and services. Now that we've talked about the role of an ACNP itself, we'll get into the competencies and standards of care that the role encompasses. There are 7 core competencies that surround the role of the acute care nurse practitioner. The textbook Hamrick and Hansen's Advanced Practice Nursing: An Integrative Approach by Mary Fran Tracy and Eileen T. O'Grady does a fabulous job of diving into each of the competencies and relating them directly to the role of the ACNP. The competencies that will be discussed are direct clinical practice, guidance and coaching, consultation, evidence-based practice, leadership, collaboration, and ethical decision-making. The first and most important of the acute care nurse practitioner's competencies is direct clinical practice. This could be described as the bulk of what practicing ACNPs do on a day-to-day basis. Direct clinical practice can be broken down into 2 subcategories: diagnosing and managing disease, and promoting and protecting health and preventing disease. There are many competencies that fall under the umbrella competency of diagnosing and managing disease. The ACNP must demonstrate a mastery level of knowledge related to the subjects and education that was required to them prior to obtaining their degree and certification. An example of this would be having an advanced knowledge and a master level of knowledge in advanced pathophysiology. They must also be able to complete both a prioritized and comprehensive physical examination. Along with that, ACNPs should be competent in rapidly assessing unstable conditions and implementing the correct diagnostic strategies and therapeutic interventions to improve the patient's condition. Depending on the area of specialization, the ACNP will have a specific set of technical procedures and skills that they must know how to perform safely and effectively. Some of these may include procedures such as endotracheal intubation, central line placement, chest tube insertion and removal, and splinting of injuries, among many others depending on the area that they choose to work in. According to Tracy and O'Grady, ACNPs have gained the ability to include these skills and procedures within their scope of practice due to there being an increasing number of ACNPs in critical settings, and complication rates of NPs performing these procedures are no higher than the complication rates of physicians performing them. ACNPs must know the indication for the procedure or intervention, as well as know the complications and contraindications that go along with the procedure. Manipulation of patient plans of care based on their changing condition is also a major competency for ACNPs. Finally, ACNPs must be able to effectively collaborate with other providers regarding patient care. The second subset competency of direct clinical practice is promoting and protecting health and preventing disease. Though health promotion and preventing disease is not as common for the ACNP as compared to, say, a primary care NP, there are definitely still areas where ACNPs play a key role in promotion and prevention. There are many health risk factors that are a part of an inpatient stay, and the ACNP must be competent in recognizing these factors and modifying them, as well as preventing or minimizing the risk of the harms that can go along with that hospital stay. A good example of this would be delirium. It is key for the ACNP to implement interventions and provide education on how to avoid delirium in the hospital setting to nurses, nursing staff, physicians, patients, and their families. The second competency for acute care nurse practitioners is guidance and coaching. Again, many would attribute this competency more towards the primary care setting. However, the ACNP is presented with many opportunities for guidance and coaching throughout a patient's hospital stay. In the acute care setting, there are often many medications, interventions, diagnostic tests, and symptoms that may be completely new to the patient and their family. It is a key role of the ACNP to provide the patient and their family with adequate education regarding these topics. There is also education surrounding what got the patient to the acute state in the first place. An example of this would be a patient admitted for DKA that refuses to control their diabetes at home and needs further education in the inpatient setting. Another area that an ACNP must exhibit strength in is educating the patient and the family about what will happen after discharge and how will they manage their condition on an outpatient basis. Many individuals do not have a primary care provider, so the education that they receive in the inpatient setting may be the only education that they receive and can be monumental in preventing readmissions. ACNPs also provide coaching and guidance to nurses in the acute care setting. Consultation can be either formal or informal. An ACNP may formally place consults to other specialties, requesting the aid in the care of the patient. Informally, ACNPs may be a constant face for a patient as their nurses, residents, and possibly physicians are always changing. The ACNP can serve as a consistent member of the patient team and is able to keep the entire team informed regarding the patient's condition and plan of care. They could be described as the glue that holds the team together. Both of the next two competencies, evidence-based practice and leadership, are key amongst all levels of NPs, but especially to the DNP. The two somewhat go hand in hand as implementing evidence-based practice takes a high competency level in leadership. One aspect of healthcare that sets NPs apart from other providers is their emphasis on evidence-based practice. Again, different specializations will utilize evidence-based practice in different ways. It is part of the ACNP's role to keep up to date with evidence-based practice guidelines and implement them both into their individual practice, as well as facilitate change for the system as a whole. ACNPs and evidence-based practice play monumental roles in implementing quality improvement initiatives, as well as creating some of the core competencies for healthcare. Tracy and O'Grady discussed the change that occurred in 2011 requiring hospitals to improve patient outcomes and maximize reimbursement for Medicare patients. ACNPs play a key part in developing ways to make this happen using evidence-based practice. Some ACNPs participate in research in order to support clinical practice change. Obtaining an advanced practice degree in nursing is demonstrating leadership in and of itself. ACNPs serve as mentors and role models for nurses, unlicensed staff, and residents, among many others. Some ACNPs may hold an administrative position, such as director of a critical care unit. Within the healthcare system itself, ACNPs must be competent in overseeing, coordinating, and directing the delivery of comprehensive clinical services, as well as promote a positive healing environment. Oftentimes, ACNPs serve as a solid foundation for a medical team. Residents commonly pass through a specialization and don't always have a plethora of experience. An ACNP can serve as a resource for residents and other nursing staff to provide a line of communication from them to the appropriate resource, such as the physician. In large facilities, there's often a lead advanced practice provider who oversees all the other advanced practice providers, and rather commonly, this is an advanced practice nurse. Though it is often done subconsciously, collaboration is one of the most commonly practiced of the competencies. ACNPs are part of the interprofessional clinical team in an acute setting, and they work together with all other disciplines and specialties to provide sound and safe care to the patient and their family. Tracy and O'Grady discussed two models of collaborative care. First, the collaborative practice model emphasizes patient outcomes with each provider responsible for providing the care in their area of expertise. This model understands that patients need care from many different specialties simultaneously to receive exceptional care and achieve positive outcomes. The second model is the patient-centered care model, otherwise known as the holistic care model, which includes patients and their families and requires that care be holistic, collaborative, and responsive. ACNPs have the knowledge to be active members of each model. There are still some barriers to collaboration that exist, such as physicians not accepting the decisions of the ACNP and honoring them, but the barriers are becoming less and less. The final competency or standard of care for the ACNP is ethical decision-making. Though all providers have a knowledge in ethics in providing ethical care, it is often thought that advanced practice nurses excel in this realm of care. ACNPs should always be an advocate for their patients. They are often a part of planning and implementing end-of-life care, which requires a great deal of ethical competence. Though the different roles and paths of advanced practice nurses possess the same main core competencies and standards of care, there are definitely parts of the ACNP's competencies that apply to the ACNP role specifically. The role of the ACNP is continuously evolving and expanding. The Institute of Medicine has highlighted the importance of practicing to the full scope of nurse practitioner practice, and this has direct implications for the ACNP role. However, it comes with its own set of challenges as well. Three of the main challenges reported by ACNPs are lack of recognition by peers and staff, unclear duties and/or boundaries, and limited exposure to critical care processes once practicing in the workforce. The next few slides will explain these challenges in more detail and how practitioners can help to overcome them. Lack of recognition or not being considered a professional peer is a frequently cited challenge of the ACNP. Often, such problems stem from inadequate knowledge of the role of the ACNP, leading to other staff's opinion that the ACNP may be exceeding their authority or infringing upon the doctor's authority. This can also lead to animosity or reluctance of staff to carry out orders issued by the ACNP. Publicizing and educating others about the evolving role of the ACNP is a continued requirement to secure identification of the role. The role of the ACNP isn't always fully understood by physicians, and therefore duties and/or boundaries aren't always clearly set. Doctors may delegate work that is out of the ACNP's scope of practice or won't delegate work that is well within their scope of practice, and collaboration between the two is then disrupted. This can also cause undue stress or burnout amongst the team due to lack of communication and willingness to work together. The ACNP and primary care physician should participate in clear discussions to set boundaries and prioritize patient tasks. This increases interactions between and the closeness of the ACNP and the physician and develops mutual trust amongst team members. Many acute care programs focus on all patients with an acute process rather than patients with complex high acuity needs. This can limit the ACNP's exposure to critical care processes. ACNPs may enter the workforce with novice feelings of inadequacy, low self-confidence, and limited knowledge. Mentorship and precepting in acute care areas can assist in improving the ACNP's transition into clinical practice, as well as educate others on the ACNP role and help to set clear boundaries. Discussed all about the role of the acute care NP. What does the future hold for the acute care NP? The consensus model was developed to address the evolving changes in APRN practice and expansion. The model also promotes patient safety and improves access to APRNs. The model had an implementation goal set for 2015, which has not quite yet been adopted by all U.S. states. It's been noticed that some employers are mistakenly hiring NPs that are prepared for primary care and are placing them in acute care settings with acutely ill patients. The model suggests that acute care NPs will need to complete a dual master's degree or a postmaster's program. After being hired, some hospitals are requiring their NPs to return to school to obtain their postmaster's degree in order to comply with the consensus model requirements. This program can have up to 7 classes and over 600 clinical hours. However, schools are now developing more streamlined programs to make the goal more attainable. Today in hospitals, we are noticing that acute care NPs are performing more clinical skills in acute care settings. Skill examples are central line catheter placements, ventilator management, and X-ray interpretation, along with all the other ones that were discussed on previous slides. They are taking on more and more responsibilities, such as teaching roles and quality improvement. The future NPs could be able to practice independently without a physician. Many NPs must pay large fees in order to receive mandated supervision from their physicians. Without these fees, the NP could see more money in their own pockets, and more importantly, they'd be able to expand their practices and treat more patients. Thank you all so much for listening to our presentation. We hope that we are able to provide you with further insight into what all the acute care nurse practitioner role entails.